Good evening. My name is Wayne Solley. I'm a partner physician with Texas Retina Associates. We're a group in Dallas, Dallas-Fort Worth area with 17 physicians and 12 offices. And recently in our Arlington office, in one of our satellite offices, we installed the Navilas system. And I've been using it about 6 to 9 months. And this evening I just want to basically give an overview of the system itself for those of you who don't really know what navigated laser is, and discuss its use briefly, but also give you a bit of an overview of how it's the benefits that I see in clinical practice. In the practice, we're all trying to become more efficient and figure out this whole treatment strategy of patients with edema in their macula from different problems, whether it's diabetic edema or vein occlusions or other problems that cause macular edema and require laser treatment. So let's just dive right in and talk a little bit about the system. When the DRCRnet Protocol T came out, everyone was abuzz about the benefits of using aflibercept for diabetic edema. And so as we all did, we began injecting to try to get our patients the best visual outcomes. The Protocol T results at 1 year obviously showed the aflibercept treatment advantage. But what a lot of people don't realize, and I didn't realize till I dove into the numbers a bit, was that nearly half of patients had laser treatment. The protocol allowed for laser rescue after about 6 months. And as you can see on this slide, nearly half of patients, even in the aflibercept arm, it was 37% of patients required laser treatment. So that was an interesting point. The other point was, if the laser was so good, why did the people continue needing injections into the second year? Because as we know, the second year results came out and showed that the Lucentis arm actually caught up to the aflibercept arm as far as visual acuity went. Things equalized after year 2, but you still, it's an interesting point that so many patients still needed laser treatment. But the laser that we used or the laser that was used in the DRCRnet was again the classic sort of old school point and shoot laser treatment, which is the same kind of laser treatment we were doing back in the 80s. And so two main lessons about that. Number one, even under really good study conditions, optimal conditions and very regimented study conditions, you still needed laser nearly half of the time. And if the laser was so good, why did patients continue to need injections? So what this system is, the Navilas system, is a combined laser. So it's a 577 nanometer, which is in the yellow range, and nanometer laser. It has microsecond capabilities. It's coupled with an eye tracking software as well as a fundus camera. And the eye tracking software actually had its genesis back in the refractive surgical realm, where you needed a tracking system that would follow a patient's eye movement, or their LASIK, for example, would be off center. And so that technology has now been applied to focal laser, coupled with some other advances. Number one, contact lens free treatment. So with this system, the patient doesn't have to have a contact lens placed on their eye. Infrared illumination, which also is much more comfortable for the patient. It's not nearly as bright. So their compliance and their keeping their eye still is a lot easier. It has import capabilities for OCT, fluorescein angiography, and also ICG angiography. So the image that you capture on third-party systems, OCT, FA, and ICG, can be imported into the system to help you guide your treatment. And when that image is imported, the treatment is pre-planned on that image. And so even without the patient in the room, the image is pulled up on the system or imported into the system, and you can plan out your treatment, plan out exactly where you want your laser spots on that image. And then that image is then mapped to, and the system, once the patient's in the chair, it locks onto the patient's eye with this eye tracking technology and couples those two images together so that the laser then can be delivered in with your pre-planning guiding the laser where it's going to shoot. But it's a very, very, very accurate system in this way, and also it's a very efficient system. That's the whole gist of laser navigation. So what's the science behind this? Well, a few studies have been done and have shown, number one, an increase in accuracy. Believe it or not, as good of shooters as we all think we are, a navigated system does do a better job of hitting those microaneurysms and hitting those small targets the first time. So a first-time hit rate of, in one study, 30% improvement. And then also, because of that accuracy, presumably, there's fewer retreatments that are needed as well. A different study showed a significant reduction in the number of retreatments that were needed over an 8-month period. Another benefit of navigated laser appears to be that with the increased precision of the laser, there's faster reduction in central retinal thickness measurement. In a retrospective analysis of 48 patients done at the Cole Eye Institute, 27 of the patients were found to have had traditional laser, after 1 month, followed by anti-VEGF treatment as needed, while 21 patients were included in the study that had navigated laser, also followed by anti-VEGF treatment as needed after the 1 month date. 1 month after the laser treatment, there was a much faster reduction in central retinal thickness measurement in the navigated laser group compared to the traditional laser group. And also, after the 3-month period, in looking back at the number of injections that these patients needed, only 2 of the 21 navigated laser patients required additional injections, whereas 16 out of the 27 traditional laser patients required additional injections. The number of injections was not a final endpoint of the study, so statistical analysis was not done on those. But a prospective study was done and looked at this exact same question. How does navigated laser ultimately affect the number of injections that was needed? In the CAVNAV study, which was a study done back in May 2013, originally reported it at ARVO in May of 2013. It looked at patients that had anti-VEGF monotherapy and anti-VEGF therapy plus navigated laser with the Navilas system. The laser was done in addition to 3 monthly anti-VEGF injections, and then in the following 9 months after those initial 3-month loading injections, the injections were done on a PRN basis, solely done as needed to maintain the gains in the vision that were achieved in the first 3 months. And looking at the results, the patients that had the anti-VEGF treatment plus the navigated laser did much better. The statistical significance was also reached when you looked at the number of patients that actually needed another injection. That was 84% of patients in the monotherapy group without the laser versus 35% of patients that were in the anti-VEGF group plus the navigated laser. And then patients that were in the navigated laser group that had additional injections, the number was significantly less. The post-loading dose phase injections decreased markedly in the patients that had also had the navigated laser. Now, this study was initially done in Europe, but then a very similar study was done in the U.S. Dr. Freeman in San Diego did another study that reconfirmed these results. And then what I have seen in my practice is again, we're all getting busier. We're all trying to see as many patients as we can comfortably. And there is a definite benefit to using this system on clinical efficiency and how quickly can you get in there and do a good job and then get back to your clinic. For those of you that do your lasers in the middle of your clinic, or even people that do lasers as a separate laser clinic, if there's some folks out there that do that. Because of this system, the initial setup and imaging can be performed by your retinal photographer, but then it's a pretty straightforward mechanism to input the image into the system and also to do all the pre-programming to get the image set to where it locks onto the patient's fundus picture when they sit down. But all that can be done by your technician. Again, it's very comfortable for the patient without a contact lens and without a bright illuminating light. It can be done very, very quickly, and patients are very compliant with it. It's very easy and painless treatment, as we know. Using that pre-planning and by pre-positioning your spot, it reduces the time of your treatment. And then also, especially as we start talking about microsecond use, it treats all areas accurately with the first treatment. And so even in continuous wave mode with central serous, with diffuse diabetic edema, vein occlusions, and then those small little parafoveal spots that sometimes you're a little hesitant to treat. And some of those may be actually very important to trying to get those last few microcysts out of the fovea. Those all can be treated very fast and very quickly and very accurately, and with the first treatment. And as I mentioned, that microsecond pulse mode, to do that, and again, I've just started doing some microsecond treatments. And with this system, because you can pre-plan where you're going to place your treatment, and because the system tracks the eye for you, in microsecond mode, you can't see where you've placed your laser burn. You can't see, you don't get a visual feedback of exactly where you shot your laser. And so if you're trying to do microsecond treatment and you don't have a visual return, if you will, on where you've treated, and the patient moves their eye a little bit, which they do, even with a contact lens on there, it sometimes can be a little bit difficult to know that you've gotten a confluent, uniform, homogeneous treatment over the area you're trying to treat, rather than double treating some areas or under treating other areas. And again, none of that's, microsecond treatment is now just kind of, more people are starting to do it. There's not a real consensus on exactly what's going on with microsecond treatment, other than we're stimulating the RPE to potentially upregulate some factors that can be helpful in getting rid of edema. And it's not too hard to search the literature and find before and after photos of improvement. So something is clearly going on there, but it's intuitive and just seems logical that if you're going to do a treatment across a large area or larger area of retina, that you want to know that you're treating it uniformly and treating it consistently. And hopefully studies will bear that out as this technology begins to get to catch on and get more people using this technology. Hopefully we'll get more statistical analysis of this technology being beneficial. So let's see what this all looks like on a real patient, if you will. This is a patient of mine, AG, a 66-year-old female. She's been type 2 diabetic for 25 years. She'd been treated with bevacizumab in the past, but she'd had none for about 2 years. She was treated elsewhere and then came to me for another opinion as her vision continued to decline. She'd never had laser before. And I was worried after talking to her, I was worried about her follow-up a little bit, given that she had just kind of gotten out of treatment for several years and then came in when her eyes were in this bad a shape. As you can see on the OCT and on the fluorescein angiogram, she has diffuse edema, widespread edema. Vision was 20/80 miraculously, but she had widespread leakage, numerous microaneurysms, and clinically she was in bad shape. So what I want to do next is show the video of the treatment itself to give you an idea of what the system looks like from the operator standpoint. And in this case, she, as you'll see on the image, she does move a little bit, and so you can see how the tracking technology keeps the laser focused on her eye.
To begin with, we take a color fundus image, and this is done contact-free and with infrared illumination, so it's very comfortable for the patient. And you saw a couple of little infrared diodes. Those are used to focus the image. So after we snap our color picture, the system shifts into the planning screen, and at this point the patient can sit back and relax. So before creating our plan, then the third-party image, in this case an FA image, an angiogram image, is imported. So once he gets the image imported, the image is then cropped before the system performs automatic registration. And so he's importing it now, and then now at this stage the system presents the results for the user to double check. And then it's imported into the planning tool. At this stage we can create a treatment plan, but we're going to skip ahead to the finished plan here in the interest of time. So this shows where we're going to set our treatment, get our treatment plan set up. As you can see on the dual image there, there's edema in the central macula, but then temporally as well there's a large area of a circinate ring, lipid exudate with numerous microaneurysms and in 3D, there's significant thickening there temporal to the macula. And so knowing this, and also knowing that there's edema superior and temporal to the central fovea, we're going to plan that accordingly. So after we bring the patient back in again, we have them sit forward and we find their pupil again and line it up. And as soon as the system recognizes the patient's retina, it begins tracking the plan. We've got our images there, and we have our plan set up. And we always want to start by treating the microaneurysms that are away from the macula first. And so we'll fire a couple of spots on our first couple of treatment areas. And you see there we selected the spot I wanted to treat. And after we treat it, the system will take a picture, take a photo, to make sure that we have our energy titrated appropriately. And so we don't have to do that after every shot. We turn that off. So we treat the microaneurysms, and then now the system jumped to the area that is that we're doing a grid laser treatment through that area of thickening temporally. And as long as I keep my foot depressed on the pedal, it will continue to treat those areas in succession. The system automatically stops if the patient's blinking too much or moving their eye too much. And after it reacquires the image and the patient's steady, the treatment can continue. And now we're treating with microsecond pulsing. It's a confluent pattern, so we get the maximum effect. We're using a 15% duty cycle. And the system treats every other spot. You notice there are the spots that are being treated. It treats every other spot first to prevent thermal crosstalk between adjacent spots that are next to each other. And then thanks to the tracking, it comes back, it keeps track of which ones it's done, and it'll fill in every other spot as it goes through the second time. And as you see, it reacquires the image. Once it reacquires the image, we can continue. And it just continues treating every other spot. And all the while, I'm not having to worry about focusing on where I'm shooting the laser, because the system has that. I'm encouraging the patient to keep their eyes still and keep looking straight ahead. So we're winding up our treatment of that first micropulse area temporal to the macula. And our patient's kind of looking around, and so you see the system fixing and refixing as their eye movements take it off screen. But after we finish a patch like that, then I select the next patch with our pointer, and then whichever laser spot I select, it starts from there. And in this case, it was the micropulse again, and so we're continuing on with our micropulse treatment. So we skipped ahead, and we're almost finished with this next patch of micropulse, and so it's finishing up. And again, you can see how it's treated every other spot, and now it's going back in and filling in the remainder of the spots. And then it finishes those up on top that we didn't hit the first time. So now we have a few microaneurysms left, and so we select those and take it out of the micropulse mode. And we finish these last few conventional treatments, and we're finished.
One of the things that I mentioned previously was how you can use an OCT image, and on our patient I didn't show an OCT image, and on this slide you see a different patient than the one we just treated. But in this case, there's a patient that just superior to the macula, there's a large area, say 2 disc area or 2 to 3 disc area of thickening, of significant thickening that's not quite in the fovea yet, but outside the fovea. And this is a perfect example of a patient that I think could benefit from the microsecond treatment. And so you see where I've pre-placed and all the small little spots for a confluent microsecond treatment. And again, using the OCT image like this, you can very, very accurately treat the areas that are exactly what you want to treat without treating areas that are not thick, and confluently treating the areas that are thickened. And I threw this case in because it was a striking example of how the technology can work. This is a 66-year-old dentist who is a patient of my partner's, who he said was extremely bothered by his small little metamorphopsia in his macula. He had a small branch lip vein occlusion just superionasal to his fovea. And you can see on his angiogram, you see on his color photo on the left that there's some lipid exudate there, just indication of chronic leakage. And just supranasal to his fovea, there are some small little irregularities in his vasculature. But again, nothing striking on this. But after a laser treatment, after a navigated laser treatment, he did quite well. The two images on the bottom of the screen show the before, where he has more intense leakage just superior to his fovea and a little pseudocyst right in his central fovea. But then on the two images on top, that's after the laser treatment, there's definitely a reduction in the edema, and that small little microcyst resolved to a normal architecture, and he was amazed how much better he saw, even with that small little change. And so, again, just a nice before and after evidence that the system does work well. And then I mentioned central serous retinopathy earlier. This is another really nice way that this system works. Now, granted, we don't end up treating as many central serous patients as we do diabetics, for example, but when you do have a central serous patient, it's a really nice way to use it. Classically or historically, what you have to do is be sure you have an angiogram picture up next to where you're treating, so you can sort of follow the vessels and try to target where you think that leak is coming from. And sometimes you could see it, but many times you can't see exactly where the leak is. With this system, you can import your image, you can pre-plan your treatment by putting a few spots right on your offending small leak, and then just let the system do the work of tracking and being sure you deliver the laser to the proper spot. And again, it makes for about a 30-second to 1 minute treatment. It's very, very quick to get the patient in there and put your 3 or 4 or 5 little laser spots on it, and you're done. And again, before is now on top and after is on the bottom, but it shows a very nice resolution in this patient. So I'd like to open it up for questions. Again, it's a lot to digest, but it's a really very, very user-friendly and technologically advanced system that I think can be an asset in many different ways. It can help your practice as much as it really does help your efficiency. It makes for a very, very quick laser treatment, and from the patient perspective, it's very comfortable, very easy, and from a scientific side of things, it does seem like it's a much more accurate system. You're delivering only the lasers you need to deliver to achieve what may prove as time goes by and as more studies come out to be a better result. So I'd like to open it up to questions at this point.
Well, thank you everyone for joining us this evening. Let's dive into some of our questions here and see what we can do to hopefully answer a few questions that you may have about the system. First one is, I've had good experiences using anti-VEGF. When do you prefer to use a laser rather than just using injections? Well, obviously, if you have a patient with a large circinate ring and a really obvious focal area of leakage, that's a classic patient I think that most of us would consider at least lasering the offending microaneurysm or group of microaneurysms. Another example is if you have a patient that's seeing quite well. Say the patient comes in and they're 20/25 and not bothered, but they were sent in by their general ophthalmologist because they identify and remember the ETDRS, where there's a little bit of thickening just outside the fovea, and that's one that you may not necessarily, or it may be at least a hard sell to the patient that you want to start them on monthly injections when they're 20/20, 20/25 and relatively happy with their vision. Some of those require a bit of education on your part to try to convince the patient that they need all these injections. I like to laser those folks because if the laser can take care of it, then, or at least minimize the treatment burden that ultimately they have, that's a patient I think that's a perfect example of laser. And so, really the ends of the spectrum of disease, the early patient that has very good vision and even the later patient that's got significant edema and diffuse thickening, I think those patients also are good laser candidates, because if you can decrease the leakage at least somewhat, you may ultimately need fewer injections or less frequent injections. If you can shoot them every 2 months, inject them every 2 months rather than having to bring them back every single month for an injection, patient's going to be happier, your clinic's going to run smoother. So I do think that using laser is definitely warranted. And again, as we said in our presentation, that was all borne out in the DRC, our NET Protocol T study as well. Okay, second question. When would you use a subthreshold treatment rather than a conventional treatment? I think diffuse areas of thickening are a good place to use those where there aren't obvious microaneurysms. Do an angiogram and you see an area that's sort of devoid of microaneurysms, but there's definitely thickening on the OCT there. That OCT example that I showed in the presentation, that was a patient that was a perfect setup for a subthreshold treatment, because they didn't have anything exactly to shoot with the laser in a conventional manner. Now, those are the ones that historically you'd put a grid across that area of a conventional continuous wave laser, more traditional focal laser treatment. But I think it's becoming a little more accepted now that that's a good patient for subthreshold treatment. And then also early disease, I think, is another good example of a subthreshold potential. Some of this still has to be borne out because there's not widespread use, I think, yet of microsecond laser, subthreshold laser, but those patients that have early disease that are seeing quite well, who you don't want to make a burn per se on their retina, you just want to sort of treat the area with photic stimulation, which is basically what subthreshold treatment does. It treats the RPE and hopefully gets it to work more efficiently to get rid of the fluid. Those early patients that have good vision, I think those are also potentially very good candidates for subthreshold treatment. Third question, what power settings do you use when utilizing yellow rather than green wavelengths? Well, yellow laser has an absorption profile that's better optimized to treat retinal tissues, especially microaneurysms that have a red color. Those the yellow absorbs very nicely on those. So more laser energy when the yellow wavelengths get absorbed where we want it to be absorbed. So yellow is really a more efficient wavelength. So you can use, in a lot of cases, lower power settings than you would have to with a green laser. Typically for focal laser, the value's been a few tens of milliwatts less than with green. But again, you have to sort of titrate it given the media opacity, lens issues and things like that. Number 4, generally speaking, do you still see a role for laser in the age of anti-VEGF? Well, as we sort of answered before, yes. I see laser as an adjunct to treatment, an additional tool, if you will. And if it can decrease the injection burden that we're putting on patients, I think that's ultimately going to be a plus. The other thing is, I think it's helpful if the science kind of bears this out as we continue getting more and more experience with microsecond treatment. I think it's a nice adjunct, to treat the patient, obviously, to help them, but also anybody can just inject monthly drug into someone's eye and say, okay, I'm treating them, and just continue to treat them every single month. The nice thing about laser is it still shows that you can think about a treatment strategy and provide some skilled treatment that is well thought out. Again, if we just relegate everyone to just monthly injection and take a tool like laser, which is in study after study after study seems to show that it's beneficial for the patient, I think it behooves us to do that as well, just so we know we're giving our patients the optimal treatment and not just generically shooting them every month. Just again, it shows we have we're listening to the science and we're doing what's best for our patients all at once. Next question: have you treated other BRVO cases with this laser? Yes, actually, I've treated several, and you know, in a more conventional fashion, using grid treatment across those areas. My partner actually has been Dr. David Callanan has been doing more subthreshold treatments than I have. I've just gotten started with that technology, but he's been doing more subthreshold treatments and has been very impressed with the way that has worked. He came to me the other day talking about how impressed he was with how his branch vein occlusion cases have responded so nicely to this laser. So that's something that we're going to be continuing to look at specifically here in the next 6 months to a year is how, because he showed me 3 cases of his branch vein occlusion cases that he had treated with navigated laser, and they no longer need injections. And so he effectively cured their edema with the navigated treatment rather than just a conventional grid. And that's something I haven't done a lot of yet. I've treated a few with this laser, but that'll be something that'll be interesting over the next 6 months to a year to look at. Number 6, in that case where you used an OCT to guide the treatment, can you use the system for a follow-up treatment when you see them again for a follow-up a few months down the line? In that case, that was a subthreshold treatment, a microsecond treatment. And again, if you have your parameters set right, the microsecond treatment, or some people call it a micropulse treatment, the microsecond treatments are designed not to cause a thermal burn to the retina or the RPE. And so theoretically, again, it requires a bit more study, but theoretically, yes, you could go back and treat again, because all you've done is with laser, stimulated the RPE. And since there's not a burn per se there's just photic stimulation, you should be able to do multiple treatments. Again, theoretically. Now, the only thing, a little asterisk, is there is, we know from just operating light microscopes and things like that, there is light toxicity that you can get ultimately. And again, I'm not well enough versed in laser physics to understand if that would be a true concern at those subthreshold levels, or if it would take hundreds of treatments to get to that level. I mean, again, that's not really, that's beyond the scope of what I understand about it. But again, theoretically, I think it'd be a reasonable thing to do. If that patient came back in and they had reduced the edema by 50%, say in 3 months, and you wanted to do it again, I'd think it'd be perfectly acceptable to do it again and try to continue to slowly reabsorb that fluid. Number 7, have you considered performing a microsecond PRP? I know there are some true believers that have done that think that helps. There have been a couple of studies that have talked about looking at, there was one I remember reading that had vitrectomy as an endpoint and vitreous hemorrhage as an endpoint in patients that had microsecond PRP versus conventional PRP, and they said that their microsecond PRP gave similar results. So, but I'm just, again, intuitively, the way I've always understood PRP to work is that you're decreasing the oxygen demand of the peripheral retina by doing the PRP. and that requires some destruction. And so the whole goal of microsecond PRP is to not destroy tissue, not to burn tissue. So I guess I'd need a little convincing on that. But again, worth looking at and worth studying. It's clear we don't understand everything there is to know about it. Microsecond treatments and what actually it's doing at the level of the RPE. Number 8, do you use this system a lot in your day-to-day practice? And what about compared to your slit lamp laser? Well, since we got the Navilas system, I've done almost every laser, every focal macular laser for sure with this system. I can think of maybe 1 or 2 patients I've used on our conventional laser that I thought either that they would have such a poor view that the tracking wouldn't work very well, or that they just seemed like my gut was that they weren't going to be able to keep their eye still enough and would be looking all around, and I wanted to have a contact lens on them to sort of help hold their eye in place a bit. So, but that's just a couple of patients. The vast majority of patients do extremely well with this treatment, and you even see in the example that we showed, that patient was moving their eye all over the place compared to where most of our patients can do. Most of them just sit there, and I really wish I had a recording of the patient that we had with the OCT guiding that area in their superior macula, because that patient just sat there and the entire laser took 2 or 3 minutes because they just sat there and it just went right along, and they had no discomfort, no glare problems. They just sat there and it was as quick as could be. That efficiency point too, I can't really emphasize enough, because in a busy clinic, as we are all getting busier and busier and busier, especially with all these injections, and that actually, I think in some really busy practices, some people opt just to go ahead and inject because they don't want to take the time to go sit the patient down and put a lens on their eye and do a laser treatment, especially if it's questionable whether it could be efficacious, or but they've got their clinic set so that they can just do injection upon injection upon injection. The beautiful thing about this system is that the technician really can get everything almost completely set up, just shy of the planning, phase where you have to click, 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 click. But honestly, that takes a minute to get your pre-planning all set up when you walk in the laser room and the patient's sitting there and the images are up and ready to go, and your cursor's right there. They've got it all teed up for you, and you just plan right where you want your laser. You tell the patient to hold still, and this will just take a second, and start going. And you can be in and out of the room in a few minutes, where previously, you'd have to coax them in, get the contact lens on their eye, and sometimes they'd blink it off, and you'd have to it's just a little more cumbersome to do the old point and shoot method. This is so much more the way I see it, user friendly, that I use it all the time now in my practice. So that's the system, and I think it works extremely well. So that was the last question as well. I just like to tell everyone thank you for joining us this evening. I can't say enough about the system. It works really, really well for the continuous wave mode, but also I think there's some very, very interesting things that are potentially in the next year or so we're going to be seeing with microsecond laser benefits. And I hope to be able to bring another webinar like this in the future when I have a few of those before and afters to discuss. But once again, thank you for your time and attention tonight, and we'll see you next time.